Radiology departments are facing a critical staffing shortage, leading to burnout and delays in patient care. What if the solution wasn't just a workaround, but was actually 30% faster than having a radiologist on site? Beyond pure speed, this model can significantly reduce operational costs by minimizing the need for on-site staff. This isn't a theoretical concept. It's an operational model already producing results in imaging centers today. In the next few minutes, we'll break down the new regulations, the operational benefits, the real challenges, and how to prepare. So, what made this shift possible? The answer is a landmark change in federal regulations. The Centers for Medicare and Medicaid Services finalized a permanent rule, effective January 1, 2026, authorizing virtual direct supervision. This means a supervising physician must be immediately available via two-way audio and video, not physically in the building. This directly targets the nationwide radiologist shortage and acts as a lifeline for underserved rural communities. This also directly addresses radiologist burnout by offering flexible schedules and reducing the strain of night shifts. But with the supervising doctor miles away, how can this possibly be safe for the patient? You'll soon see how it can improve safety. We've covered the what and why. Now let's get into the how. How does this model generate these significant benefits? The core mechanism is workflow optimization. A single remote radiologist can oversee contrast studies at multiple sites at once. This efficiency allows imaging centers to extend their hours, offering evening or weekend appointments and increasing patient access. Now back to the safety question. Remote supervision requires a higher level of standardization for emergency protocols. This is enabled by technology. High-definition two-way cameras and HIPAA-compliant platforms put the radiologist virtually in the room. The absolute rule from both CMS and the ACR is immediate availability. The system must guarantee an instant response. Is this model being adopted in the real world? Let's look at how policies are already changing on the ground. States are already adapting. California is updating its laws to formally recognize virtual supervision for technologists. For rural hospitals, this is a turning point. They can offer advanced imaging without the cost of a full-time on-site radiologist. The result is patients get critical diagnostic services close to home, improving outcomes and keeping local clinics viable. But the path to implementation has obstacles. It's important to understand the legitimate concerns and opposition. Some professional bodies, like the ASRT, advocate for a licensed practitioner to be physically present, creating regulatory friction. Some radiologists also worry that remote work could devalue their on-site role or lead to reduced reimbursement. Overcoming these issues demands preparation, starting with staff. Technologists need ongoing training in virtual emergency protocols. Next, the technology must be flawless. This means high-speed, dependable internet and secure platforms with built-in fail-safes. Finally, compliance has to be airtight. Use software that automatically logs all supervision activity for CMS audits. So, let's connect these threads. How do the benefits, regulations, and preparations create a new reality for radiology? Remember that 30% faster response time? That statistic is the direct result of combining workflow optimization with rigorous training. This is a new operational model that improves economic efficiency, patient access, and clinical quality when executed correctly. And the development doesn't stop here. AI integration will further amplify radiologist expertise, helping prioritize urgent cases. So, what does this all mean for your organization as you plan for the future? Remote contrast supervision is no longer a fringe idea. It is a CMS-approved, economically proven, and necessary evolution. Unlocking its potential depends not on technology alone, but on deep collaboration between every part of your clinical team. The 2026 deadline is approaching. The time to assess your technology, define training, and build your workflows is now.